give me a moment here. I'm trying to get rid of something. There we go. That way I could see the whole screen on my end. So anyways, I always giggle at doctors who say, oh, I don't use rubber dam when I do endodontic therapy. And to me, it's like, well, why even bother? I mean, the AAE has been very adamant about the use of rubber dam because if you're trying to eliminate bacteria within the root canal system, then why are you going to reintroduce bacteria through saliva if you can't keep it isolated and keep it dry? So I always giggle when I hear doctors say I don't use rubber dam. But we in the American Association of Endodontics have really mandated that the rubber dam is essential for root canal treatment. I tell my referring doctors, if I can't get a rubber dam around the tooth, I can't do the endo. So no endo, no endo, no rubber dam. That's just our philosophy, and that's just the way that we do things in our practice. And in close to 30 years of doing this, I probably have had maybe 5 or 6 cases, come along that I just, for whatever reason, cannot get a rubber dam around the tooth to isolate it. So therefore, then I end up recommending, extraction of the tooth. When we talk in terms of rubber dam, let's really kind of go through how this all came about. In 1864, it was Dr. Sanford Barnum who introduces the rubber dam because he was just tormented by saliva everywhere. So he was looking for a method to try to help keep saliva out of his working environment. And then in 1882, it was Dr. S.S. White that really introduced the use of the rubber dam punch to try to help maximize the ability of punching a rubber dam so that he can isolate teeth. And then in the same year of 1882, it was Dr. Dolores Palmer who designs the very first set of rubber dam clamps. So rubber dam usage is not new to us. It's been around for an extremely long time, well over 100 years, and its use in dentistry is well documented. When we look at rubber dam, we know that there are 2 basic types. We have what we call the latex, and then of course the non-latex. With latex, traditionally they come in either 5x5 or 6x6 sheets, and there's various thicknesses. You guys have noticed that if you look at your own line, there's everything from thin to medium to heavy to extra heavy, and each thickness has its own predominant usage. So heavy restorative dentistry, they tend to like the heavy rubber dam, and sometimes even the extra heavy. We have to be a little careful sometimes with the thin rubber dam because the tensile strength in that is so weak that it rips very easily. So I'm not a big fan of thin itself, and in my hands, the medium really is what we typically use for endodontics. It's just about the right thickness to be able to isolate and to pull tissues and other things out of the way. You notice that there are various colors as well, and when we look at this, the dark itself, the greens, the blues, some of the darker colors, these are really great for better visual contrast. So if you've got a dentist who does a lot of intraoral photography, or they're underneath the scope per se, and they just want to get the best contrast, they're going to tend to use the darker shades, whereas the light is better for translucency. And so I use a beige in my own office in my hands, and that helps me so that when I go to place, say, an intraoral radiography sensor, I can actually see underneath of that. Light transmits through the lighter shades better, so that way I just kind of know where I'm at. Now, there's also a shiny and a dull side to most rubber dams, and so ideally you want the dull side to face the clinician because that will help reduce the eye strain itself. In terms of non-latex, non-latex really only comes in 6x6 sheets. You're familiar with the FlexiDam. In my own practice, I don't use the FlexiDam just because it has such a smaller tensile strength. So for me, it just is not as strong in certain areas that I would like it for what I do for single tooth isolation. So there's another rubber dam on the market that you should be aware of that is used in a lot of different programs throughout, that's made by Ultradent, and it's called Dermadan. And this is a synthetic non-latex type of rubber dam, and this is what I use just because it is probably the closest to latex in terms of tensile strength when I go to put it in. It doesn't tend to rip, and it's not as flexible. Flexi-Dam is a great rubber dam, but sometimes it's just too flexible for my own personal taste. There are advantages and the reasons why we want to use rubber dam, and when we talk about these, you know, I try to teach that there's a patient protection aspect to this, but not only is there a patient protection aspect, there's also this self-protection aspect if you're a clinician. In terms of asepsis, it's really only the dental dam that can prevent bacteria from continually entering a root canal system. So when I see doctors talk about not using rubber dam, I just want to shake my head sometimes, because it's like, why are you doing endodontic therapy and you're trying to remove bacteria, but you're doing nothing to keep bacteria from re-entering the whole system? But it's also kind of interesting to note that not only is rubber dam good for, and I'm talking just for the endodontic side, it's good for, we want to have it on during our access, of course, during our instrumentation, anytime that we irrigate, because, you know, the irrigating solutions, they're not always the best tasting stuff. But there's been a trend in the last few years with the American Association of Endodontists where we're really advocating that we want to use rubber dam even during our post and core placements, because what we're seeing is that if we take teeth that have been endodontically treated, there's got a perch in the canals, and now we take all of the temporary restorative materials on the tooth off, and we're not isolating the tooth, we're just now exposing the obturation material to bacteria again, and what we're really trying to do is prevent any bacteria from working its way through that aperta to then possibly cause a reinfection down the road. So now we're advocating strong use of rubber dam even during post and core placement itself. In terms of better visualization, you know, using rubber dam really creates this dry fill that helps reduce mirror fogging. You can put a rubber dam on and you can stretch it, and that stretching ability retracts the mucosa of the lips, keeps the tongue out of the way. It just makes life so much easier. But more importantly, if I don't have fat cheeks and a big old tongue in the way, I don't tend to hit them with my rotary instruments. So I can actually protect soft tissues by keeping a rubber dam on place. And personally, I think it makes you a more efficient clinician, because you're able to get in and you can get into the system and you can work pretty good, because you're not having to fight all these extraneous things, you know, tongue, lips, saliva, all that other kind of stuff that takes up most of your time if you don't have a rubber dam on. In terms of irrigation, the rubber dam is great for keeping fluids confined within the tooth chamber that you're working on and out of the oral environment. You know, because let's face it, if you've never tasted bleach, that's probably the most disgusting taste around. So therefore, you know, we want to try to protect the oral environment from, you know, our bleaches and our EDTAs and chlorhexidines that we use. There's this great little product here that Ultradent makes too, and it's called Orasil, and it's just basically a putty that if I place a rubber dam around a tooth, and if I got a leaker, meaning that, you know, the rubber dam is probably not as tight against the tooth as we'd like, and I get saliva that kind of works its way up through the rubber dam, there's a caulking material that you can place in there, and it just kind of dams it up, and it helps keep that saliva in check. And really all this stuff is just a denture adhesive, but it just works really good. It gets wet, it expands, and it kind of plugs it up. There's also some light cured materials that you can use. Ultradent makes another product that's a dental dam, which is a light cured kind of semi-composite. You can kind of work it around the tooth, hit it with your light, and it'll set up, and that's a great product as well. More importantly, of course, we always want to prevent our patients from swallowing or aspirating the instruments that we use, because this is not a good day. In terms of self-protection, I try to teach clinicians that not only is it for your own advantage in a clinical setting, you know, by reducing aerosols and keeping the potential of transmission of systemic diseases kind of at a low key, you want to try to protect yourself as much as you can. Not only protect yourself, but you have to protect your staff and those in your work environment. So what better way to keep all those aerosols from going all over the place? And one is, of course, by the use of rubber dam. But there's a self-protection in terms of litigation, because unfortunately in the United States, we do live in a litigious society. to where the first thing that we want to talk about is, well, I'm going to sue you. Well, you know, I try to teach that if you ever have to go to the board, you got to protect yourself, because there's not a single dental board in the United States that doesn't advocate the use of rubber dam. And if you're not using rubber dam, the boards are going to consider you below the standard of care. More importantly is, if you ever have to go to a jury trial, you're going to try to convince the jury that you're above the standard of care. Well, you know, to try to do that, I guarantee you that that clinician is going to lose the case every single time. So basically, let's just not be that guy. Let's just try to use our rubber dams and protect patients. So if we really kind of break down rubber dams in itself and the clamps that we use, we have what we call a winged clamp and a wingless clamp. And so I kind of want to help you to understand the differences between both of these. In endodontics, we do a lot of single tooth isolation. And so a wing clamp for me is ideal. I don't even have wingless clamps in my office. Now, if I'm a restorative dentistry and I'm doing full mouth, you know, or working in quadrants, the wingless are ideal. I can go in and I can place a wingless retainer around a tooth, stretch the rubber dam over multiple teeth, and that just helps me. Wingless, the disadvantage of wingless is that the rubber dam tends to kind of come up over the clamp a little bit. So sometimes a wingless clamp doesn't keep the rubber dam down as much as we would like to. And that's why you would use a heavy or an extra heavy gauge rubber dam, because those tend to stay underneath the wingless clamps better than, say, a thin would. A thin would slide right over that wingless clamp really easy. Whereas a wing clamp, I've got these little wings here on the side that really help keep a rubber dam in place. And so that's going to be important for us as I go to show kind of little secrets on how to place a rubber dam. In terms of clamps, every dentist has their favorite clamps, and every dentist is trained that there are a certain set of clamps that we use in dental school, and there may not be a whole lot, but you know, if we look at what is really out there, there's so many clamps that I'll guarantee you none of them know, you know, which clamp to use on which tooth and what that particular clamp is designed for. They all have their basic minimums, and I'm no different. I basically have kind of 5 everyday clamps that I go to. I use a 00, a 2, a 9, a 12A, and a 13A. And then I have 2 backup clamps, the 56 and the 2A. Now, I like these particular clamps in my particular clinic because I don't have prongs that dig down deep and bite into the gingiva. You know, most of the clamps that I use, they have kind of a flat shelf to them. So let's kind of break these down. So the 00 clamp, this is a clamp that's predominantly for anterior teeth. So this is, you know, upper, lower, canine to canine, because these teeth are skinny, they're narrow. The beaks on these are really kind of nice and narrow. It fits really nice around the tooth. So I use a lot of 00s for anterior teeth, as well as the number 9. This is sometimes referred to as the butterfly clamp. And this number 9 is ideal as well for anterior teeth. I went to Southern Cal, and this was our clamp of choice. I can put this on just about any tooth in the mouth and make it work, just because I know, you know, how this clamp works. And what's nice about this particular clamp is you know, you get a little bit, these wings out and through here are far enough away that you can kind of get in and work things, but it's got such a small adaptation around the tooth that this is really good for some teeth that are broken down, that, you know, you just can't get a normal clamp on. These are ideal for those types of teeth. I also use a number 2 clamp, which is predominantly a bicuspid clamp, either upper or lower. And that's about the only time I use this number 2. It's just really for bicuspid teeth. And then on my molar teeth, I like 2 different clamps. There's a 12A and a 13A. And basically what you're looking at is we have a wider beak right in through here, and this wider beak goes against the buccal surface of the tooth, and this would be against the lingual surface of the tooth. So you can see the 12A would be for our lower rights and our upper lefts. And then if we say we need to go to the lower left and upper right, then of course we have a clamp designed for that, where the broader side of the beak here goes against the buccal surface and on the lower. And you can see how single tooth isolation is ideal. It clamps the tooth very easily. So this is the clamp that I use for all of my molar teeth. Now, I very rarely do palatal injection, meaning that I very rarely get the roof of the mouth numb, because these beaks don't dig down deep into the gingiva, so they really don't pinch the gums. And so I can safely go in and put this in and can very easily eliminate having to get a patient numb on the roof of the mouth. Because if you've never had that done, let me tell you, that'll knock the tears out of your eyes. It's not the most comfortable way to get a patient numb, and I try to avoid that at all costs. The other two clamps that I talked about in my arsenal that I have is a 56 or a 2A. Now, I would use a 56 for molar teeth that no matter what I do, I just can't get a 12A or a 13A on it. And these are predominantly these teeth. Sometimes we get these molar teeth that are just huge, or the crowns are just too bulky. You can't get the clamp to spread far enough to even get over it. The 56 is ideal for that. It gets over that. It just fits better on really big teeth. So that's where I use that. The 2A clamp is, again, a bicuspid clamp, but the difference is the beaks down in this area are broader than what the 2 is. And so this clamp here is ideal for that case where a doctor has prepared, say, a molar tooth for a crown. They've got them in a temporary. I don't like going through temporaries to do endodontic therapy, so I take my temporary off and I look at the build, or I look at what's left of the tooth, and sometimes it's not always the ideal crown preparation, and I don't have enough resistance to try to put a normal clamp on a tooth. So these 2As work really well in those situations where I've got a tooth that's been prepared, it's smaller, it can kind of hang on to it. So I use the 2A predominantly on teeth that have already been prepared for crowns and molar teeth. So what are some tricks to putting the rubber dam on? Well, for me, I always try to put the whole thing on as a single unit. So what I do is I will literally take my dam and I will place it on the frame. You know, I take my wing clamp and I place it. So you can see the rubber dam is underneath of the wings right in through here. And then I can just take this as one unit and go right in on top of a tooth. And once I place it around the tooth, then I can just pop off the rubber dam off the wings and stretch the rubber dam, and I'm ready to rock and roll. And so this is a video of my buddy Toda out in LA. We were classmates together, and I wanted you to see how easy it is for him to put, this is a number 9 clamp on a molar, but just look how easy it is to put a rubber dam on. So when I have a doctor says, oh, I struggle trying to put this on, and it's like, this is like 5 seconds. I don't understand what the struggle is. You know, and we're going to see it from a different angle. I want you to see just how quick and easy and how smooth it is to put a tooth, do single tooth isolation with a rubber dam. You know, bam, what did that take him? Seconds to do. And again, he's going to pop off the rubber dam off of the wings to make sure it's isolated. He'll double check everything, and they're ready to go. Now, there are instances where no matter what you do, you can't get a rubber dam on a tooth. And so there's a different type of things that we can do. And this is called a split dam. And basically, if I have a tooth that's so broken down, I'm going to use this right in here as what I'm talking about. There's no way I can put a rubber dam clamp around this particular tooth. And I don't want to clamp the gums here because that clamping could cause that gum to die. And I don't want that. So I can take a rubber dam. I can make 2 small punches next to each other into the rubber dam material and take a pair of scissors and literally cut a little channel between those 2 hole punches and create a slit in that dam itself. So now if I go in, I can put a retainer, a 00. This is a 00 over this one tooth. This is where they placed the rubber dam and they've ligated it. That's what you're seeing here. This is just some dental floss. They've ligated it. But now I've got total access to this tooth, and you can see that the rubber dam still conforms right up against the gums and the gingiva. So this is called a split dam, and this is ideal for cases where you just can't clamp a tooth. And do I use this? Oh yeah, you know, because you should see what I see in my office. there are instances that no matter what you do, you just can't get a rubber dam on it. And so that's where the widgets really come into place, because I can go in and I can punch my rubber dam, I can put it around the teeth, I can use the widgets to kind of basically ligate, in between the contacts. I see a lot of this on younger patients, children who still are developing and the teeth aren't fully erupted. And because they're not fully erupted, it's really hard and challenging to get a rubber dam clamp around that tooth, just because I don't have enough tooth structure above the gums to really clamp. So my backup now is to use the widgets. It keeps the rubber dam in place. Phenomenal product. You guys all know it's, either available in latex, non-latex, different sizes. In terms of COVID-19 and what we've got going around, are we going to see an uptake in rubber dam use? It's really hard to say. I'll tell you what I am seeing a lot of right now is, daily kind of stuff coming from different manufacturers that are talking about, these extraoral suction systems to help keep aerosols down and all that other kind of stuff. And I look at this and I go, well, this is a great toy that, a company's trying to make and sell, because let's face it, dentists don't put rubber dams on, and there's a lot more aerosols when they don't do that. We can even get creative if you want and try to create something to try to minimize the spread of aerosols. Whereas in my opinion, I think that if we stick to the basics of using rubber dam, you're going to minimize the aerosols that are out there anyways. And I think using rubber dam is a much safer approach in dentistry. Do I think that we're going to see more use of rubber dam? It's really hard to say. I think that maybe for the first quarter, 1 to 3 months, some general dentists, are probably going to say, well, let's try to minimize the aerosol spray, so let's start using rubber dam. And then they're going to go through the nightmare of dental school, to where it took them forever to put a rubber dam on, for quadrant dentistry. So I think that you're going to probably see this initial rush of rubber dam usage, but within about 3 months, I just pretty much have this sneaky suspicion that we're going to be back to where we were originally. And once doctors kind of get out of that fear mode, they're going to be back doing things the way they normally do. So I don't think we're going to see a tremendous amount of change in the way that dentistry is done, because we're already all trained to, to maximize our exposure or minimize our exposure to patients' systemic conditions. So we want to try to minimize our exposure to that. So, we're a profession that has been in the forefront of always trying to do that. So in today's fear of COVID-19, I think you're going to see some initial stuff, but then I think within 3 to 4 months, you'll probably see that those are going to kind of go away. Any questions about rubber dam at this stage before we transition and move on into electronic apex locators?
I can give you a question.
Oh, of course.
Yeah. Hey, it's Jeff Pearson, Dr. Gray. How are you doing today?
Good, Jeff. How are you?
So when you went back to that, back to the kind of the early stages on there, that, what was it, the Dermadam, that Ultradent product that you use?
Yeah.
It's a non-latex material.
Yeah.
Is that true?
Yes. Yes.
Is that something that you use for use with retreats and doing chloroform?
Sure. That always kind of comes. Yeah, that always kind of comes up. What if chloroform gets on a rubber dam? Does it melt it? Well, on a latex, sure, it'll melt it. Now, the thinner the rubber dam is, the faster it'll dissolve that. I use the Dermadam, like I said, just because I like the way it feels. It's probably the closest to having a latex rubber dam on. And I find that, if I get a little bit of chloroform on it and it comes out, I don't really have a lot of dissolving of the rubber dam that goes on, but I'm real careful with my chloroform that I use. We have a system in our office in place that I just kind of use it sparingly, more by the drop versus, pouring a big bucket down. So some offices will just get in there and they'll just go to town and they'll squeeze the syringe and it goes everywhere. Well, I really use it literally by the drop. And so in my hands, I don't have that issue, and it's not a problem now. In somebody else's hands who may not do a lot of retreatments or perhaps think they know how to do retreatments, they might get a little sloppy. Therefore, I think more of the chloroform on the dam can dissolve it. But I just don't have that issue just because I kind of know what I'm doing. Hopefully that answers your
Well, yeah,
question.
I've had an endodontic group that's kind of come to me and said, hey, your dam breaks down when we use our chloroform, and we want to use a non-latex product. We found this. Do you have anything that will compete with it?
Yeah. And because I'm not a FlexiDam user, it's hard for me to compare the non-latex version that Colting has. I've tried to use it. It just didn't work in my hands, which is fine. So I haven't seen the FlexiDam response to chloroform because I just don't use it. So I don't know if it breaks down more. I know that the dam itself has less tensile strength, so technically, yeah, it's possible it could break down more. It's just a personal thing. I just don't like the way it feels in my hands. So
Hey,
yeah, if you got an
Dr.
endodontic
Gray,
group, yeah.
I just another quick question about how you select which hole size that you would use for clamps or.
It's funny that comes. I'm just big. I just go big all the way. It just makes it easier for me to put the rubber dam retainer or the rubber dam clamp in there. If the hole is too small and then you try to stretch it around a wing clamp, they tend to rip. So I just go with a large size on my punch, and I use that for all the teeth. It's just kind of preset, and I really don't have issues with the rubber dam not adapting to the tooth, because still the hole that I'm punching is still way smaller than what the tooth is. So therefore, we don't spin the dial and try to make a selection based upon tooth size and hole punch size. We just leave it on big and away we go.
Well, just if you ever use FlexiDam again, I recommend going with a smaller size because it's so flexible that the smallest size punch will allow you to really kind of get that around the clamp and not have too much or too large of a hole so it's loose. But that's what I always recommend in any office that has that same problem with the FlexiDam.
It's not the whole size that throws me on the FlexiDam, but that's fine. Any other questions?
No, thank you.
Cool. No worries. All right, so let's let me kind of move this off my screen again. All right, so let's go into working length itself. Now, working length basically is a distance from a predetermined coronal reference point to where we want to take our cleaning and shaping and our obturation material all the way down to a point where it should all finish or where it should end at. And so in order to understand this concept, let's kind of take a look at some root end anatomy, because everything that I'm going to talk to you today about now is based upon anatomic and histological landmarks. And so I'm going to use such terms as apical constricture, and I'm going to use another term called apical foramina. And there's a difference between both of these, but we tend to throw these terms around, and they tend, unfortunately, to be used kind of like they're interchangeable, and they're not. So when we talk in terms of what the apical constricture is, basically, some individuals will call this the minor apical diameter, and this is really where we consider this the smallest diameter of the root canal itself. And this is what we talk about where we want to try to finish most of our endodontic therapy. So this is, a lot of times you'll hear me talk about the apical constricture. And so this is the apical constricture right in through here. It's the place where it's the thinnest part and where this gets closest together inside of a root canal system. And this apical constricture changes as we age in life as well. And so as we age in life, it might get thicker and it might get longer. But this is the point right here. It's this narrowest part inside of the root canal system itself. This is the ideal place that we would like to try to terminate our gutta percha at. in terms of what the apical foramina is, the apical foramina is not the minor apical constricture. This is an area at the end of the root, which is really the opening on the side of the root that allows the nerve tissue, the blood supply, and the dental pulp, all that stuff passes into this area. So this area, realistically, right in this area, this is the apical foramina. This is the part of the tooth where this nerve bundle and everything enters into the tooth. So you have apical foramina here, and then you have the apical constricture up and through here, okay? So how do we find out just where to finish our root canal? Well, we have two methods of doing that. One is we have a method called the radiographic working length. And then, of course, we can find that apical constricture either as well through an electronic apex locators. So let's talk about the radiographic working length and how we obtain it. So pre-1994, or excuse me, 1994, pre-1994, if you went to dental school, this is kind of how we learned how to determine how long a root canal system was. This is how I learned in dental school. So basically, we would try to estimate the working length from the PA. So prior to digital radiography, we've all seen those small little x-rays that the dentist likes to hold in their hands, and they like to, you know, close their eye and hold it up to the light and look at these things. They're small. But what we would do is we would basically hold that x-ray up, we would take a file and we would superimpose it against that x-ray to try to get a predetermined little working length that we could ideally come up with, and then we would place a 15K file to that estimated working length. We would take a picture, and then based upon what we saw in that picture, we would either adjust it, either pull it back, push it forward between 1 or half a millimeter to a millimeter. And then if we figured out that we were just too far away from it, we would adjust it again and then take another picture. Well, let me tell you something. If you're a dental student trying to do this, this is a 3-hour process. It just takes time, and it, you know, you either push it too far or not enough, and then, you know, you go wait in line, take a new picture, and by the time, you know, it's all said and done, you just tell Mrs. Smith, gee, it was great to see you for 3 hours. We got our working length, and I'll see you back next week, okay? In reality, if we really look at it, this is kind of what we're talking about doing. We have the stopper and we try to have a coronal reference point. We place it in there and we take a picture. But what we were really finding was that the radiographic apex is not where the apical foramina is located. And normally if you take a picture and if you find that the file tip is all the way down at the very end of the root, you're going to be long 90% of the time. And so what we were finding is because the apical foramina is not here at the radiographic apex, but they're generally up a little higher on the side of the root. And so we would take our picture, and 90% of the time the file tip would be out the end, but on the x-ray it would look like we were dead on. So what we would teach is that if you find that your file tip is at the end of the root or the radiographic apex, then we would teach, well, you know, subtract that length 1 millimeter and then you should be good. Well, then apex locators came along. And so let's kind of talk a little bit about apex locators, how they work. And I want you to understand that the idea of using electricity to try to determine the length of a root is not brand new. Cluster, you know, in 1918 was starting to look at how he could devise something to measure the length of roots. And it really didn't go very far until 1942 when Suzuki conducted a study where he used a direct current through dogs' teeth. And what he found was that there was this electrical resistance that had this constant value between the periodontum and the oral mucous membrane, or the PDL, okay? Again, 20 years later, it was Sindata who came out that actually took a lot of these early research articles, put it all together, and he created and constructed this very simple device that used a direct current to measure the canal length. And what he was able to show was that the location of the apical foramina could be estimated due to a resistance. So there's an electrical resistance between the periodontum and the oral mucous membrane, and he found that it had this constant 6.5 kiloohms. And so no matter what he did and no matter what test he did it in, that 6.5 kiloohms was always consistent. And so therefore it allowed for the construction of the very first apex locator. Now, I think this is predominantly probably one of the most important papers that are out there. Husanian in 2008 really wanted to do a study that compared the accuracy of either using the radiographic technique or using the electronic apex locators. And so he conducted this experiment where it was really simple. He didn't use a lot of teeth. He took 20 teeth, and these teeth were slated for extraction either due to periodontal disease or orthodontic extraction or something of that nature. What he did was he broke them down into two groups. He took 10 and 10 of each, and in 10 teeth he used the radiographic method to try to determine the working length, and once he figured what that was, they fixated the file in the tooth and then extracted the tooth. And then on the other 10 he did the apex locators, used that file, fixated the root, extracted the teeth, and then they trimmed down the last 4 millimeters of each of the roots that the files were in so that they can measure exactly where that file was in relationship to the constricture. And what he basically found is that with the teeth that he used a radiographic determination on, that the file tip was averaged about a 0.5 millimeter from the apical foramina. Whereas when he used the apex locator, he found that the file tip was much closer to the apical foramina, and it was only 0.12 millimeters away from the apical foramina. So his conclusion was now that the apex locator length determination was significantly more accurate than trying to utilize the radiographic technique. And it was this paper that really started the use of apex locators in undergraduate programs. And so when this paper was published, a lot of the programs now felt pretty good about making the switch from radiographic techniques into using apex locators. And for those of you who call on schools today, you'll now notice that apex locators are pretty much standardized within all the different school environments. So these students are now learning how to use apex locators. And then, of course, you always want to still take a picture to verify it once you have your link. This is a pretty important paper. With the evolution of apex locators, we're constantly trying to get better. We're constantly trying to be more accurate. And so apex locators have really kind of gone through these generations where we have evolved. Every so often we kind of get a little bit better, a little bit better. And so what I want to do is I want to break this down just a bit here, and let's just talk about 6 generations of apex locators. Okay, so this is a little history lesson. I'm going to try not to lose you because, let's face it, this is physics and some of these other things, and I'm not always the best at it. But our first generation, these were known as resistance apex locators. And what they did is they took a single flow of current and they measured the resistance. And this resistance was measured, say, from the top to the bottom of the root. So it was in an up and down motion, okay? The problem with these first generations is that the patient, no matter how numb they were, traditionally felt discomfort when they were used because they were using a really high current, 150 hertz, and that got some attention. They later went and kind of adjusted that down into 5 microamps, so to try to reduce some of the discomfort patients were feeling. The very first apex locator on the market, realistically, was the root canal meter, 1969, out of Tokyo. The problem with these teeth, these apex locators, they're very unreliable, and you couldn't use them with pacemakers. But these are some of the examples that later followed under this first generation. So in an attempt to try to get better, we went into a second generation, and these are known as impedance apex locators. And this measured opposition to the flow of alternating current or impedance. And what I basically mean by that is that if you look at the inside of the tooth, say the canal itself, instead of measuring in an up and down motion, they're going to measure from side to side. So they want to try to measure the impedance across the walls of the root. And as you get deeper into the tooth, closer to the end of the tooth, the impedance is greatly increased. And so that's how they're reading the number. As they advance down, the impedance increases as you get closer towards the end of the root. Well, they used a single high frequency impedance, and this is what they used instead of resistance. So this is the first major change. So they went from measuring up and down to side now. The problem with the second generation is these produced measurements that were really inaccurate, and you constantly had to go in and recalibrate them, especially when you got close to the PDL. And these were some of the early ones on the market, the Sono Explorer, Apex Finder, some of these names you may have heard of. Now, generations 1 and 2, these Apex locators really today are not on the market anymore, okay? And these generations 1 and 2 were the only ones that used a single direct current. So after the second generation, single direct current really wasn't used anymore. And then we evolved into this third generation. And this is the majority of the Apex locators that are on the market today. These are all third generation Apex locators. They're very similar to the second generation because they're still going to measure impedance side to side. But now what we're going to do is we're going to start using multiple frequencies rather than just one single frequency. And so as you would take the file and advance down the canal, you're having two alternating currents that reads the impedance side to side until it reaches that maximum value down at the apical constricture. And the frequencies that they predominantly using in the early versions were 1 kilohertz to 5 kilohertz, and they were kind of alternating back and forth. Well, in 1994, Root ZX was introduced, and in my opinion, the Root ZX is the Apex locator that revolutionized the way that we take our measurements in endodontic therapy. I mean, this was my Apex locator of choice for many, 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 many years. Well, what the Root ZX did is that they still had multiple frequencies, but this was the first time that they were able to establish a frequency that could self-calibrate. And they also changed the impedances. They went down to 0.4 kilohertz and 8 kilohertz at the same time. And so that just kind of gave them a better accuracy and that type of stuff. What we see on today, these are various ones that are on the market. I'm going to really talk about the predominant players. My belief, even though I can't prove it 100%, but I am pretty confident to tell you that the Canal Pro falls within this third generation. There are some of these Apex locators that could use up to 5 different frequencies. So the amount of frequencies, between 2 to 5 is proprietary towards whatever that particular company's Apex locator is. But this type of Apex locator really today is still driving the market. Everything is still pretty much third generation. A fourth generation, basically, this was Kerr Endodontics. They kind of came out with adaptive. So they also used the multiple frequencies, but they only used one frequency at a time, and it traditionally was between a 0.5 and a 4. Again, this was impedance, but this particular method had a really significant disadvantage because it required a dry or just almost semi-dry canal. And that just isn't practical to try to use in today's environment. We have a lot of moisture in canals. We maybe have heme in our canals and other things. So the fourth generation really didn't go over very well. And so an example of this, we're talking 2003 with the Elements unit. It just had its issues, and it just, that requirement of it being a really totally dry canal, it really kind of sunk it down. So generations 4, 5, and 6 are kind of post 2003. Generation 5, these were developed to try to overcome the difficulty of using a system within a dry canal. But we still found that you had to have a dry canal in order to use this, and to the point with 5th generations that if you had a dry canal, you really almost needed a lubricant or some type of irrigation material inside of the tooth in order to get these to work. Realistically, the types of apex locators that are on the market that are 5th generation, we don't really see in the United States. Most of these, I'm going to be as polite as I can say, most of these are kind of Asian themed apex locators that we just don't really find over here. So we don't see a lot of 5th generation apex locators here in the United States, unless maybe you're shopping on Alibaba or something of that nature. The 6th generation really is a term that was devised, by the Elements people. They were trying to overcome the problems that they had in the 4th generation, so they devised and updated their apex locator now to basically work with both wet and dry canals. And again, we're talking about the adaptive apex locator. So I don't really consider 6th generation a true generation. I just feel that the 6th generation is a marketing ploy to try to overcome the problems that the original adaptive apex locator had on the market. So generations 4, 5, and 6, I don't give a whole lot of credence to, because those types of apex locators don't have a large share of the marketplace. Pretty much everything, in my opinion, is still tailored around the 3rd generation, impedance-based, multiple frequencies, that type of thing. In terms of the Canal Pro, the apex locator that we're using, I want you to understand that this is a impedance-based. It uses alternating currencies of 2 frequencies to measure and compare this as this file moves down, and that's basically how it reads. So when I read, what this Canal Pro is, it falls within 3rd generation. You should be familiar with how we use the apex locator, and you should be familiar with the various screens. That the reason I really like this apex locator so much is just the visual feedback that I get. That, as I introduce my file, I'm getting visual feedback from both the tooth side, as well as I'm getting feedback from a closer view when I'm getting into the apical zone. I really kind of like how I get a different color variation as I get closer into the apical zone. And so, we know that the apical zone itself is divided into 11 segments, going from 0 meaning the apex, all the way up in through this apical constriction. Now, the 3 green lines represent the theoretical apical constriction. Remember, I mentioned to you that this will either get bigger or larger as you age in life. And then as we start getting through that theoretical zone, as we start getting in towards the apical foramina, that's where you'll start to see, the yellow lines that kind of start coming in. Endodontists are going to measure differently regardless. I try to get most general dentists, when they're using this, I tell them to finish at this 3rd green line right here, okay? I might take mine to what I call the virtual apex, which is a little bit into this 1st or sometimes 2nd yellow line. Dr. Alborz loves to take his all the way down to the 3rd line. And that's just a matter of, what your education is like. If you're going down into this level, you're kind of creating a stop as well for your gutta percha to finish at. In terms of measurement, we talked about the apical constrictor being those 3 green bars. This is the recommended procedure. This is generally where we want to terminate our working length at. This is where we would like our obturation material to terminate at. But what I try to teach is that you just can't take a file and introduce it into the canal and stop as soon as you get the green bars, because you don't know how long this apical constrictor is. So I always teach doctors to take the file all the way through until the word apex appears, because what you're really doing is you're really kind of calibrating the length of the canal space. Once that gets to that point where you're into the periodontal ligature, then you back it up into the 1st green zone, because now you've confirmed what your constrictor should be, and so therefore you back it back up to there. If you were to come in and stop right here and say you have a patient that's older and that constrictor is longer, that's going to appear short on your x-rays. So apex locators, who needs them? Honestly, I think we all need them today. If we want to be more efficient and we want to be more accurate, I think apex locators are the way to do it. We've already discussed the accuracy. We've talked about the study that shows that. This definitely, it doesn't take me 3 hours like it did in dental school. I can get this in a matter of seconds. And again, there's a difference between the radiographic apex and the anatomic constrictor. So this is my apex locator that Amy sent me. Still works today, but I'm going to turn it on. Now, what you've noticed is the probe is unplugged. I turn it on, I let the unit calibrate. Once it's on, then I plug the probe in. And that way it knows that it's not in the same canal from the previous tooth. As I introduce my file, I get immediate visual feedback. And so you'll see where I pass it. I'm now into the apex. I'm confirmed that I'm through the foramina. Now I'm going to start to back it up and try to get into that bottom green line, first yellow line. That's the zone that I shoot for personally. And once I'm there, I set my stopper, and then I can pull my file out and make my measurement. But you can see how steady that screen shows and how easy it is to get a measurement. Whereas with the old Root CXs, what I don't like about the Root CXs is it constantly comes down and this jumps around an awful lot. Whereas when I use the Canal Pro, it's just a steady. I don't get that jumping around. Really important study. You will get this question all the time. And so Wilson, basically in 2006, he wanted to find out, is it really safe to use apex locators and pulp testers with patients who have implanted cardiac pacemakers or the defibrillators that are placed. And so his study basically came out and said that it's safe to use any apex locator because there's no interference between the apex locators and the functionality of pacemakers or the cardioverter defibrillators that are implanted in patients today. There was really only one study previously to Wilson's study that kind of suggested there might be an interference, but Wilson's study in 2006 really kind of put that aside. So when I have a patient that has an apex or that has a pacemaker or defibrillator, I don't lose any sleep because I know I've got Wilson's study that backs it up. Boy, isn't that the truth. Any questions?
I have one comment, Dr. Gray. We've been teaching that the Canal Pro Apex locator is a 4th generation, and it's based on a couple articles that have been written, and I'll send those to you.
Yeah, because I'd like to see them because I question whether or not it's really a 4th generation.
Yeah. Okay.
Any other questions? Does it make sense, hopefully?
Yes. Thank
Good. It's like Bueller. Bueller. Okay, well, listen, hey guys, I appreciate your attention. Feel free to email me if you have questions. Feel free to hit me up on a text if you have questions. And I'll turn the time back over to Amy.
Thank you very much, Dr. Gray. Everyone, continue to send any ideas you have for future workshops, and have a great weekend.